the approval of these highly effective incretin-based therapies have certainly revolutionized obesity care, and they've set a totally new bar in terms of what pharmacotherapy can demonstrate in terms of total weight reduction, as well as improvement in a lot of obesity-related comorbidities. The most advanced or the most highly effective and my first and second choice are tirzepatide and semaglutide, and tirzepatide and semaglutide can generate 15 to 20% and 10 to 15% weight loss respectively, depending on the patient population that you're looking at. So that's really the new bar when it comes to what we can hope for, what we can expect in terms of weight loss with pharmacotherapy. With orforglipron, this ATTAIN-1 data results demonstrates a 12.4% weight loss over 72 weeks in people with obesity without diabetes. And we now have a related ACHIEVE trial, which was studied in type 2 diabetes, demonstrating 7.6% weight loss. So when comparing the weekly injectables that I mentioned in orforglipron, this does fall short. And there is a very significantly clinical difference with regards to what weight reduction we could expect. That being said, if we compare this to maybe other oral small molecules, this is the greatest weight loss that we've seen to date with an oral small molecule medication. The only comparator really is, say, Qsymia, which is combination phentermine topiramate, and that met that kind of 10% weight loss threshold in their clinical trials, but with some potentially more severe potential for higher risk of some severe adverse events. So I think when comparing, I guess, among the small molecule medications, this is really impressive results. So where do I find this, and where do I think it will fit in the obesity treatment paradigm? I think it's those who are unwilling to take injectables, those who are unable to, really don't want to. This is when I would offer an oral medication. Whenever we think about weight loss, we always care about someone's metabolic and physical health. Those metabolic markers are things that we always look at, since we know that leads to cardiovascular risk reduction. The ATTAIN trial results have only reported, top-line results so far, and so they reported the C-reactive peptide or CRP improvement of 47%, and that is rather impressive when we think about a reduction of inflammation, since we know that is what is a significant risk factor for heart attacks, strokes, etc. We don't really have any other cardiovascular risk marker data yet from this top-line results of ATTAIN-1, but we do have the full manuscript of ACHIEVE, which again was that the orforglipron studied in type 2 diabetes patient population, and that we see an improvement in lipid profiles. We see a reduction in triglycerides, reduction in LDL, as well as an increase in HDL. And then a rather impressive A1C improvement of 1.6%. Again, compared to any other oral small molecule medication, that is really impressive data. But my one caveat is we can't necessarily guarantee that a small molecule GLP-1 receptor agonist will confer the same degree of cardiovascular risk reduction that we see with the peptide molecules. So when we look at semaglutide, tirzepatide, we see improvement in MACE, both in obesity without diabetes, as well as in obesity with or in the type 2 diabetes population, depending on the trial we look at. And until I see that data of the measurement of cardiovascular outcomes, I don't think we can guarantee that we're going to see that same result with a small molecule. The availability of a once a day oral medication that has good oral bioavailability, I think does have advantages in terms of convenience. In terms of what a patient chooses, it is variable. I think a tremendous number of patients if they were going to pick between a once weekly injectable and a once oral daily pill, most would pick the once oral daily medication. Not everybody, though. Some people, in terms of just thinking about their long-term adherence, they have a difficult time taking an oral medication every day, and they actually prefer, okay, once a week, I know where I'm going to be. I'm usually at home. I'll take my weekly shot. Others, they actually it hinders their adherence because they might be traveling for business or on vacation, and they don't take their injectable medication, and then they're off of it for 2 weeks, and then they don't end up restarting it. So I think it is a mixed bag in terms of what a patient prefers. And ultimately, if we have these choices and just more tools, more armamentarium options, I think that is definitely a win for patients. All GLP-1 receptor agonist medications or even GLP-1 based medications have some degree of gastrointestinal side effects: nausea, vomiting, constipation, diarrhea. And that the orforglipron data in ATTAIN-1 is no exception. It did report 33% nausea, 24% vomiting. I do always look at the discontinuation rate due to adverse events. In this trial, it was 10.3%. At first glance, that does seem, maybe even higher compared to some other GLP-1 medications. But then when you look at the ACHIEVE data, it actually is closer to what we see in terms of, with other GLP-1s. So I think when I look at the totality of the data, these side effect profiles are rather comparable among this and once weekly injectables. So I don't think GI side effect profile will ultimately play too much of a part in medication selection when choosing among these GLP-1 receptor agonists. So with these GLP-1 receptor agonists, the data of the benefit that we see in obesity-related comorbidities is just accumulating. Seemingly every week, there's some new trial demonstrating benefit in cardiovascular disease, renal disease, obstructive sleep apnea, osteoarthritis, metabolic liver disease. I mean, the list keeps getting longer and longer. And so that just demonstrates the robust ability for this mechanism to not only achieve weight loss, but achieve these patient-centered outcome improvements. The fact that this is an oral small molecule, I think has particular advantages when it comes to increased access. When in the United States, the access to GLP-1 based medications is nothing short of abysmal. The lack of insurance coverage for these medications, the cost out of pocket if insurance doesn't cover it is too high and is cost prohibitive. And that really needs to change. And my hope is that the approval and availability of a small molecule non-peptide medication, might drive down the price. The cost of manufacturing a small molecule is less than a peptide, and just the sheer increased competition and of different agents will drive down price and improve insurance coverage. So I think these incretin-based medications will become very widely used and as effective as statins and blood pressure medications when it comes to preventing cardiovascular disease and cardiometabolic disease. So I'm really happy with seeing these data, and I'm really excited about the next several years in terms of the continued transformation in obesity care.